Here and start.
Yeah, ma'am. Please start.
Please start, ma'am.
Shahapur district Thane, hailing from Maharashtra, Hindu by religion and Kathore by community.
Ma'am, you were audible. Kindly go ahead. Ma'am, you are not audible. Hello. Cannot hear the presentation.
Hello, can you hear me?
Yes. Yeah. You are audible now, madam. Kindly.
Oh, thanks. Hindu by religion, Kathore by community, brought by parent with complaint of 4 episodes of blood in omitus. Child was apparently all right before the onset of symptoms. He developed 4 episodes of vomiting, spontaneous in onset of moderate quantity. Two episodes of black tarry stools, which were
Cannot hear. Rajesh, Anjali writes cannot hear.
Zoom is, there's a signal with the Zoom. Yours is gone off, Zoom.
Not responding.
screen share. Being live streamed. Bye.
ओके कर एक बार स्टॉप शेयर कर मैं वहाँ पे शेयर कर ये मिनट स्टार्टिंग
Good evening. 10-year-old boy, second by birth order, born of non-consensuous marriages, resident of Shahapur district, Thane, hailing from Maharashtra, Hindu by religion, Kathore by community, brought by parents with complaint of 4 episodes of blood in omitus and 2 episodes of dark colored stool. Hello, can you hear me?
Yes, we can hear. You can go ahead.
Okay, thank you.
We can hear, madam.
Child was apparently all right before the onset of symptoms. He developed 4 episodes of vomiting, spontaneous in onset of moderate quantity, non-projectile, non-bilious, and blood was reddish in color and contained visible blood clots. The episodes were not associated with pain in abdomen, nausea or retching, and also not associated with pain. He also passed 2 episodes of black tarry stools, which were semi-solid in investigations were done there. Child has received a PRC and FFP transfusion, IV antibiotic and hemodynamic support. Then child took DAMA from there and came to our side for further management. Then, no history of lethargy and decreased urine output to rule out shock, and no history of abdominal pain or fever. No history of clay color. No history of any other bleeding manifestations. No history of neonatal umbilical sepsis or umbilical vein catheterization. Secondary portal vein thrombosis due to injury or surgical intervention. Then no history of systemic infection to rule out infective or inflammatory etiology. Intervention. Past history, child had similar complaints PRC transfusion during the both admission, and however the child has taken DAMA and was subsequently lost to follow-up. ANC history registered, supplements were taken, TT injections taken, 2 ANC scans were done, told to be normal, and no history of any ANC related complications. Birth history, full term normal vaginal delivery. Birth weight was 3 kg. Baby cried immediately after birth. No history of NICU stay and discharged on day of life 3. Immunization history till 5 years of age. And developmental history, child has achieved all age appropriate milestone in all 4 domains. School going children studies in 4th standard and good scholastic performance.
Later.
Later. Anthropometrically, weight is 15.3 kg, which falls between less than calorie requirement is expected is 1800, observed is 1250, and deficit is 550 kilocalorie. Total protein expected is 30, observed 21, and deficit is 9 gram per day. Family history, father is 35-year-old farmer and mother is 34-year-old housewife, and he has one elder sibling which is 14-year-old, and patient is 10-year-old.
Rajesh sir, you are on mute. Rajesh sir, you are on mute. We cannot hear you. You have muted the presentation, sir. Kindly unmute.
Now you can hear us?
Yes, sir. Yes, sir. Yes. Thank you.
Okay.
Thank you, sir.
Yeah. So blood in vomit in a 10-year-old child. So what are your thoughts on that?
Upper GI bleeding.
A, upper GI bleeding.
At first, we will rule out any oral cause of bleeding which might have come in the vomit test before directly to sir, and then
Yeah. So you're right that there could be some streaks of quantity. Then you get to know that this is moderate quantity and it contained visible blood clots. So this is not just from the mouth. So it is from a blood vessel, right? And acidity and gastritis. So how will you differentiate?
If it was acidity or gastritis, it was associated with pain and other
In gastritis, you don't get a big frank amount of blood. Okay, fine. Then could it be you've seen some hemophilias, you have seen some whichever bleeding disorders. Have they come with hematemesis?
if it was a bleeding disorder, then there will be other bleeding manifestation also. Here there is only history of hematemesis and melena.
Very good. So one is that, and the second is that usually this is not the first manifestation in a bleeding disorder, congenital. What about any Yeah, but ITP doesn't usually cause big bleeds, internal bleeds like mucosal bleeds. It will cause small bleeds. So, which are the two situations where you can get hematemesis due to a ads? Of course, that's not the only reason. There's of course varices and all that, but it can add to that thing, right? Okay. Anything else? Can it be a
Deulefoy's Deulefoy's lesion is there one AV congenital, AV malformation that can also erosion of that vessel can lead to a massive bleed.
Yeah, so theoretically it can, but it won't be usually passing 2 episodes of black tarry stools. What does that mean?
Upper GI bleed, because the episodes are black tarry stools, not fresh bleed or not associated with any tenesmus.
It's just this upper GI. You a black tarry stool. If it was a very small bleed, it wouldn't have given, right? Okay.
I think what is important is there is a hematemesis, but there is also a dark blood passed via rectum. Do you think both can occur at the same time? Apparently, it looks like both occurred at the same time. Now, how can any bleeder right? So now start stomach coming right down would take 8-12 hours. If two things have happened together, there has to be two different lesions.
It could be the same lesion, just there might be two bleeds from the same lesion, or there's just separated temporally. For example, that melena would have started earlier. It has become manifest at the same time.
His second, as he said, he could have bled from the upper lesion earlier without becoming manifest, and that came down as melena. There are multiple possibilities, right? Okay.
So, which means that what you said is right. But suppose any child presents without obvious that after all, when he brought out lot of blood, he must have been oozing inside, which has gone down. But suppose there was no severe hematemesis, he would have come to you with only black colored stools. Would you have considered portal hypertension without hematemesis? So give a thought. I'm sure this is straightforward portal hypertension. But because there was a black colored stool, I thought we will discuss a different way the same disease presenting. So, any thoughts of what I'm trying to say is that how do you judge that there is small amount oozing, which stomach manages to pass down and avoids a lot of vomiting. Some thought.
So the small amount fully through the intestines and create the melena. If there's a sudden large bleed, that's going to distend the stomach, that's going to cause the vomiting and a fresh hematemesis.
Even if this patient would have come for the first time to you, saying that there's a black color stool, it means it is coming from the stomach because the acid is turning it black. And the point I want to make is just because you have given this happens rarely because most of them come with large amount of hematemesis. But because you mentioned black colored stool, I thought I would take you to that level. And black colored means it has been acidified. And therefore, that's enough to say that. Had it been any other local abnormality, like say polyp, it would not have been black. So that black colored is seen. Okay, right?
Intestinal, would it have been black, sir? There's not acid there, but there are digestive juices. Maybe upper intestinal, not necessarily stomach, could also be bad. There has to be enough time for the blood to get modified and discolored and going as well. But higher. The lower you go down, the more fresh is likely.
Okay, so now right. So in your mind, you are trying to decide whether this is prehepatic portal hypertension or sinusoidal or hepatic portal hypertension. Sinusoidal.
Sir, there is no history of confusion or altered sensorium and behavioral changes. And there is also no history of clay-colored stool, pruritus, jaundice, and it can be pre-sinusoidal.
So the first thing which you mentioned of confusion, etc., is about encephalopathy. That will be only in the last stage of liver disease. So when a child comes with hematemesis, why is it important is that somebody who has a chronic liver disease is kind of semi-compensated. But when this child suddenly has a bout of hematemesis, he or she gets pushed into further dysfunction and that can trigger an encephalopathy. Is you asked all the questions. Your questions for sinusoidal are also no, and your questions for pre-sinusoidal are also no. So in this situation, which of the two do you think is likely? Or it's something else? You got my point? You have no neonatal catheterization. So there's nothing for pointing to pre-sinusoidal also, right? And you have no jaundice and all that. So nothing pointing to the liver also. So what more do you want to ask or you want to say that it can still be this?
I have not asked so far.
You got getting my point? So I'll make it more and more pointed. I am asking if there is no child. Answer that. Can be. So then what will tell you whether it can be or it can't be? What question you want to?
Because compared to my मतलब tenderness and with the pain and in this child, the child was otherwise active and alert, only otherwise active.
So like she said, no jaundice does not rule out a liver disease. May not have, right? So she said there could be other symptoms of liver disease. So what are these other?
Yes, sir.
Then that is important, no? Huh? Okay. Then you would have asked for abdominal distension.
Sir, there is abdominal distension and pedal edema also. I have described.
Important. So that's the thing we are trying to teach and we are trying to learn, that you asked 10 questions of no history, which are good. But in spite of these 10 questions, if we can't be sure, is it pre-sinusoidal or is it sinusoidal? That means there are more questions to be asked, right? So one was edema, one was abdominal distension. Most important was growth failure, then general activity, playfulness of the child. Okay, all this was for sinusoidal. And the important thing is that pre-sinusoidal need not always have that neonatal history, no, of catheterization and all that. Right?
If this child has a chronic liver disease, since we say that it's varices, will that child be absolutely normal all along with a chronic liver disease, giving rise to cirrhosis and portal hypertension? No. Growth normal, appetite normal, activity normal, playful, nothing is there. And the child has gone to chronic liver disease so much so that he has varices, and that happens. As active as before. He's now got a little progressive. We find that his abdomen is little progressively distended. He's not very active. We find that the upper abdomen is more distended. His appetite has gone down. So an absolutely normal child will not have sudden decompensation. The past history must have been there. If there was no past history, then you can think of case of decompensation being absolutely normal all these days. So this subtle history has to be brought.
Okay, now look at the growth. So interpret the growth. Less than -3 standard deviation is fine, but I want a deeper interpretation. Sajad, try. So tell me, what is the height, age of this child, and what is the weight age? And weight age is? At what age would you get 15 kg as a perfect weight? At what age? 3.5, 4 years. 4 years. So his height age is 6 years, weight age is 4 years, and he is 10 years. So chronic malnutrition pattern, but in a 10-year chronic malnutrition pattern of height and weight both affected, but weight affected more he has less food to eat. This is because something is wrong in his body, long chronic illness, right? So that history which we discussed was important. But anyway, if you just look at this growth only, then also you say that this is more likely to be means he is stunted and wasted both, no? So you can't say thin. Yeah.
Like 6 years, grown like 6 years, weight is 4 years. And his chronological age is supposed to be 10 years. So he is not growing for last so many years, and not only growing, not putting on also. So this is what was most important to tell you. What appeared as something which has happened now has not happened now. It has been cooking up for last so many years. Maybe the parents have not noticed, or we have not brought out that from our history.
In summary, 10-year-old boy with history of hematemesis and melena with anemia with similar past history, no significant birth and developmental history, immunized till death, is a case of upper GI bleed. It can be esophageal variceal febrile. Heart rate was 120 per minute, RR was 38 per minute, saturation was maintained, BP was 98 by 60 mmHg, peripheral pulses well felt, central pulses well felt. Ear normal, extremities normal, back and spine normal, abdominal distension present, pedal edema present, genitalia normal, and hernial orifices intact. Then on systemic examination, on per outdoor examination, on inspection, abdominal distension present and umbilicus was central and everted, visible veins present over abdomen, not dilated or tortuous, no scar, sinuses or visible lump, no flank fullness and hernial orifices intact. On palpation, inspectory findings are confirmed on palpation. On superficial palpation, soft, non-tender, no local rise of temperature, no guarding or rigidity. On deep palpation, liver not palpable, Spleen was palpable 3 centimeter below left costal margin along the long axis. Smooth in surface, firm in consistency, rounded border, and splenic notch not felt. Percussion dull note present, and on auscultation vowel sound hard. On RS, air entry bilaterally equal and clear. On CVS, S1 S2 present, normal, and no murmur. On CNS, TPR was normal.
So see, we'll have to try and be a little more clear here. So when you said abdominal distension was present. So it was, you saw it yourself, meaning which part, upper, lower, or general, or what did you think?
Generalized abdominal distension.
On palpation, what do we expect?
If there is a generalized abdominal distension, it can be ascites, uh, ascites or hip organomegaly.
Excellent. So it can be organomegaly or ascites, right? Now look at your findings here. So we have no liver, no
Uh, Sir, about free fluid, matlab, if it was mild ascites, then
what I'm see, we are learning. What I'm trying to explain is you will get such borderline cases in exam. Liver also and not having free fluid also, this is not fitting in. So one of the three things is not correct. Either there's no abdominal distension only, or then I am missing fluid, or
on percussion there is a dull note.
so that percussion dull note I was going to ask you further. That is, then you have to describe it as a horseshoe shaped dullness or no. Because again, it would mean rarely, if you don't have a horseshoe shaped dullness, but you have dullness, then you have to wonder whether this is a cyst in the dull note where? All over some particular area.
Sir, dull note around the umbilicus.
So this needs a little careful interpretation, because you have to confirm that in the planks there was no dull note. And if you say so, then that means this is not fluid. So then you start wondering whether this is some other mass, some lump, etc. Right? So we'll have to be abdominal distension. And the second thing, which I hypotonia, and in a standing position, it may look like abdomen.
If there was dullness around the umbilicus, because if there is gaseous distension, there will be resonant node around the umbilicus. There's dull node around umbilical, that means there has to be a mass set. The respiratory rate of 33, 122, isn't that so? And abdominal distension might of fluid, whether there is more fluid in the flanks or it's all anterior-posterior. So we are trying to judge from the physical examination what is likely to be there inside the abdomen. It's fluid or it's gas. Because always the intestine will come in front and they will give you resonant note. So that is what I was not able to understand why. So
Uh, 10-year-old boy with history of upper GI bleed, with severe anemia, with similar past history of hematemesis, no significant birth or developmental history, immunized till date, thin by antro and mild ascites and splenomegaly, is a case of esophageal variceal bleed secondary to portal hypertension with extrahepatic portal venous obstruction. No, sir, no hypertension. Then on investigation, on CBC, HB was 3.8, and then hematocrit was 12.2%, WBC was 3.9, neutro predominant, platelets is 1 lakh. OTPT also normal. Total protein is 5.5 and albumin is 3.3. Then alkaline phosphate is 10. Of cavernoma formation with hepatopetal blood flow in the collateral, and mild splenomegaly, moderate ascites, and altered liver ecostructure with surface irregular nodularity. This was the child's outside investigation. So recent investigation on 4th September. On that CBC, HB was 1.4 gram per deciliter, and then SCT is 6.1. Counts are 17.8 thousand, neutro predominant. Platelets was 7 lakh, and RBC was 1.04, and MCV is 59, MCS 13.1, MCS is 22.2, and PTINR, PT is prolonged 38.8, and INR is 3.61. And LFT here is also LFT is normal, but total protein is 5.3 and albumin is 3.2. And investigation, other investigation at the time of second admission when child was 6-year-old. At that time, HB was 4.9. Hematocrit 9%. Counts are 2001.96. MCH is 25.26 and MCS is 30.82. And here, portal venous Doppler study has shown changes consistent with the portal hypertension. For this child, OGD scopy done under the general anesthesia. Finding was GEJ as 25 centimeter, and there was a esophageal varices involving long segment, 3 column seen, and red color sign seen in 2 out of 3 column, and endoscopic variceal ligation performed. On
I think if you go to an adult ward, you will find cirrhosis with portal hypertension and hematemesis. In pediatrics, we don't see that. And in adults, cirrhosis, and even without jaundice, because it's a compensated cirrhosis. Why don't we see compensated cirrhosis? Because when you showed me the weight is so low, height is also so low, we could have discussed why not a chronic liver disease. And you also said some puffiness. Understand how two things are a bit different, right? Anyone, give a thought. Okay, books won't write. Liver diseases primarily come with hepatocyte dysfunction, and most of them are either get better by themselves or get worse. Progression is very fast, that you don't see much. But when do you see cirrhosis which is compensated? When there is a very slow progression of a hepatocyte damage. That typically happens with alcohol, for example, or sometimes the silent hepatitis B. And I think that is one reason why. But always keep in mind, because there is a possibility that slowly progressive hepatocyte disease may present with cirrhosis. But when I was trained, and even when Dr. Khare or even he must have seen, there was a condition called Indian childhood cirrhosis. That typically came with cirrhosis, portal hypertension, etc. And nobody knew to begin with why that Indian childhood cirrhosis, till we realized that it was a copper poisoning. And that poisoning was slow, like an alcoholic poisoning, which is slow. And then the manifestations occur usually much earlier than adulthood. And that's why they don't see much.
Any questions, any comments? Okay, so
Extrahepatic portal hypertension was not expected in this particular child, going by the history. The child has been undernourished, not doing well. 10-year-old child, like 6 years, weight gone down, edema feet. Now, edema feet is a result of malnutrition, anemia, severe, and the liver diseases due to other, and portal hypertension due to third cause. And these three things occurring together was rather difficult to imagine. And absence of hepatomegaly may not always mean, if sometimes you are able to get a edge of the liver to see, or left lobe, is you may be able to feel a very hard liver, and that is enough for you to say that, well, this is not a normal liver. So till such time that you came out with the final diagnosis, we were always kept chronic liver disease in mind. What was the cause of tachycardia and tachypnea? 34 respiratory rate, 112 heart rate when the child was admitted. Anemia.
Yeah, Ramakrishna sir, you want to say something? Ramakrishna sir, you wanted to say something?
Thank you very much for giving the opportunity, sir.
Yes, sir.
Pranams to Professor Y. Amdekar and Rajesh Chokani. I am Ramakrishna Paramahamsa from Andhra Pradesh. Just I would like to know, because there was interruption in the telecast, I missed how the periorbital edema is explainable in this patient. We don't expect periorbital edema in a child who has portal hypertension. We don't go by the lab parameters, but there are no signs of hypoalbuminemia, and it's not a condition with low oncotic pressure. But still, there is periorbital edema, which is not a feature in the liver disease or a portal hypertension. Can I get the
Yes,
clarity?
yes, sir, you're right. So now we can only guess whether that time the child was in kind of cardiac failure secondary to anemia, whether that, or we really don't know because we've not seen the child, so we don't know whether there was genuinely periorbital edema and how much. But you're right that we are not expecting it in portal hypertension.
Thank you, sir.
Thank you, sir.
Good evening. Today my case presentation is about Siddhi, a 6 years old female child, taken by birth order and born out of non-consanguineous marriage. She is hailing from and resident of Aurangabad. She was brought by mother with complaints of abdominal distension on and off since last 1 year, and complaints of loose stools on and off since last 8 months, and complaints of decreased generalized activity of the child for 3 months, and complaints of generalized swelling of body for 2 months. History of presenting illness: the child was apparently fine till 1 year back, after which around July 2024 she has that day, non-projectile, non-bilious, and not bloodstained, and it contained undigested food particles and water. It was not associated with the abdominal hospital, where sonography of the abdomen was done, and parents were reassured, and child was sent home on some symptomatic medications. Following which, the abdominal distension got relieved gradually on the same day as the child has passed stools. 2 months later, the child again started having complaints of abdominal distension, which was acute in onset, painless and progressive, associated with history of increased passage of flatus present. And again, she has received some symptomatic treatment, and the distension relieved in 1 day gradually. In the intermittent period, child had no specific complaints. Loose stools for 8 days, which was around 7 to 10 times per day. Watery inconsistency, frothy appearance was present, and history of oil droplets floating over the stools noticed in the stools by the mother, the water seal, and it was difficult to flush. Which is present in the lower abdomen, which was dull aching in nature. There are no aggravating factors, but the abdominal pain gets relieved on passing stools. And the child had significant history of weight loss from 19 kg pre-illness to 17 kg in 4 months. Parents were told that the child's blood levels are low, and she received one PRC transfusion. An ultrasonography of the abdomen was done. The parents their course of stay, she received some IV medications and she was discharged on oral medication. She was told to improve hemoglobin and the child got symptomatically better. Again, during March 2025, she again started having complaints of loose stools associated with abdominal distension, occurring intermittently for 2 to 3 days period with periods of normalcy, which last for around 15 days in between. Also, she had again lost weight from 17 kg to 15 kg this time. She was consulted with the gastroenterologist in Aurangabad, where some powder was prescribed for weight gain, and her loose stools and anemia medications and some loose stools and anemia medications were given. Following which, she started gaining weight initially, and the symptoms resolved temporarily. But again, during May 2025, she started having complaints of loose stools along with abdominal distension with worsening severity and duration. That is, these loose stool episodes complaints of easy fatigability in form of child started refraining herself from playing due to pain and lethargy, which gradually progressed to child could not climb the stairs without support, followed by she could not walk without support. And there is history of difficulty in squatting while using washroom. Once initially noticed by the parents over the legs, followed by it progressed to involve the abdomen and face. It was not associated with any diurnal variation. There is history of breathlessness on exertion present, but there is no history of palpitation or nocturnal awakening due to breathlessness. Also, there is significant weight loss present from 19 kg pre-illness to 13 kg in 1 year, which accounts for 30% of weight loss. There is no history of decreased appetite present, no history of jaundice or persistent recurrent vomiting, no history suggestive of any vitamin deficiencies, no history of recurrent respiratory tract infections or any previous surgeries, and no history of COX or COX contact present or any known foodborne or airborne allergy present. History of similar illness in a family member. In her maternal cousin, she had similar complaints at 12 years of age, and she underwent some surgery, details of which not are not completely known to the parents. Past history is uneventful, antenatal history uneventful, birth history insignificant. Developmentally, child has attained all the age-appropriate milestones prior to the illness. She is currently attending school. Diet history, her expected calorie intake is 1,400 kilocalories, actual calorie intake 1,250, and her expected protein intake is 18 gram, actual protein intake is 21 gram. There is no protein deficit. Child is currently on gluten-free diet. Child is immunized till date according to National Immunization Schedule. Clinical summary is
What are your thoughts? Edema. Okay. Gaseous. Okay. Anything more? So you said gaseous, fine. Obstruction. So it is not just gaseous distension, but you are also looking at 3 or 4 vomits. But at the same time, they are non-projectile, non-bilious, non-blood stained, etc. Now, he was taken to a hospital and abdominal distension got relieved after passing some stools. So now, overall, what would you think of this episode, and then there are many such episodes further. So what would you think?
Probably child is having bloating, like gaseous distension of abdomen, which is getting relieved as the child releases the flatus and she's passing the stools, it is getting relieved. And intermittently, these episodes are keeping on happening.
If this is happening again and again, and if there is lot of gaseous distension, then why is that happening? That's the next question to think, no? So what do you think?
Probably the carbohydrates are not digested and there is more gas production in our bowel.
Very good. So one issue you have to think of is whether are problems for calling it mechanical, like we said, it was non-bilious, etc. And then what's their pain at that time?
During the first episode, there was no abdominal pain.
Because usually, even if it is a subacute intestinal obstruction or intermittent intestinal obstruction, there is pain also along with that, right? So these are the ways you will try to think of both mechanical versus non-mechanical. Okay. And then he had 2 or 3 similar such episodes, right? Yeah? Okay.
I think the history would have suggested acute surgical problem. But which medical condition may simulate such a problem?
Dynamic intestinal obstruction.
Hypokalemia.
And therefore, typically a paralytic ileus. Okay. But paralytic ileus doesn't get well quickly. So then what is it? Looks like a medical condition, but simulating an acute surgical obstruction. But it's not paralytic ileus. Then what else it is? Why should there be then? Some kind of an irritation of the intestine, could be malabsorption, could be immune mediated inflammation, but unlikely an infection. That much we know. Okay. And it is recurrent, often self limiting. So, what happens suddenly? Immune disorder, and now add one more, immune disorder of the intestine, also causing loose stools and severe weight loss. Now, where do we stand in all that? Just by that history.
So that's what you think. Now, later you have these oil droplets noticed in stool. So what does that mean? Of fat. So you have fat malabsorption, and earlier you had suspected a carbohydrate malabsorption. Okay. Now you have history of weight loss. So these also look like intermittent obstruction, no? These episodes. So now intermittent obstruction and weight loss. So then to yes or no? Correct? There are repeated episodes of intestinal obstruction. In fact, you also have loose stools. So you have alternating diarrhea and constipation, what is written in the books. And you have got weight loss. So that means this is quite fitting into intestinal tuberculosis. So any thought? thoughts on that? Applied also. So malabsorption is against tuberculosis.
Intestinal tuberculosis usually affects the cecum and the later part of the intestine rather than the small intestine, which is mainly responsible for the malabsorption. Absorption.
Child is generally not having any lethargy, decreased activity, and child's appetite is throughout the illness time. Child's appetite is always good, and that is
So two things. Any such malabsorption would lead to weight loss. So just because of that, you don't bring in weight loss and say this is tuberculosis. But most important is this malabsorption is which layer of intestine? Intestine has four layers: muscle, mucosa, submucosa, uh, one more, and muscles. What is the which layer is responsible for malabsorption? Mucosa. And tuberculosis affects which layer? Submucosa. So that is the other important point, right? So what I just wanted to bring to your notice is that superficially that history did look like a recurrent intestinal obstruction. Would you just join to weight loss, you might get into tuberculosis, but this is definitely not tuberculosis. Fine, I think so. Now, sir already summarized it as a acute onset. So, I mean, sudden episode. So, immune and involving the mucosa. So, there's some malabsorption also. And therefore, now what's your differential?
so in clinical summary. She is a 6 years old female child who was brought with complaints of intermittent episodes of loose stools with bloating, with abdominal pain since last 1 year, which was associated with history of significant weight loss and easy fatigability and anasarca, with past history of anemia requiring blood transfusion. Mm. Yes. On examination, child was afebrile, thin built, heart rate around 134 per minute, tachycardia and tachypnea is present, saturation is maintained, peripheral pulses are well felt and extremities are warm. BP is
On inspection, child looks malnourished. Abdomen is distended. Is icteric.
The child is thin built and child is having tachypnea at rest. Is tachypneic at rest and pallor present, and then para-abdomen distension is there. Mm. Weight is more affected than height. Sir. She's 5 years. Her height is fine, but weight is more affected. The height is 10 centimeter, which is between 0 and +1 standard deviation. Height is fine, but weight is less than -3 standard deviation, and the BMI is also less than -3 standard deviation. She is severe thin with the wasting.
Meanwhile, others, is there clubbing? Is there platinichia?
Sir, on palpation, abdomen is soft, distended. There is no organomegaly. Umbilicus is centrally placed.
The para-abdomen liver is palpable, sir, around 2 centimeters below right subcostal margin, but liver span is around 7 centimeter. It is and mm.
The border of the liver consistency is not very soft, soft to firm. लांब श्वास घे बाळा. घे आणि सोड लांब घे श्वास आणखीन लांब घे I think the spin is just palpable. Not a very soft abdomen. As I go down, something like a doughy feel of the abdomen as I go down, especially on the left side. There's no particular mass that is pain, but I think there is a doughy feel of the abdomen. Liver is certainly enlarged, firm. Spleen, I don't know, unless I turn her to right lateral position, she may be just palpable. For she's technique distension. There is a suggestion that sometimes there are some visible peristalsis seen, especially in the upper abdomen that I've been seeing that from the beginning. Otherwise, there's nothing much. Yeah.
My case summary is a 6 years old female child, taken by birth order and born out of non-consanguineous marriage, brought with complaints of intermittent loose stools with bloating, with abdominal pain since last 1 year, with associated history of significant weight loss and easy fatigability and anasarca, with past history of anemia requiring blood transfusion, who on examination is having abdominal distension with hepatomegaly, is probably a case of chronic diarrhea, probably of small bowel origin, with features of malabsorption to rule out autoimmune enteropathy, second inflammatory bowel disease. So the child's CBC on presentation was total counts for 11,200 with neutrophil predominance of 62%, hemoglobin was 10.2, hematocrit was 32, and platelets were 2,09,000. And her VBG, the severe electrolyte, her pH was 7.25 on presentation, suggestive acidosis, and then she had a severe electrolyte disturbances, hyponatremia, hypokalemia, also hypocalcemia, hypoalbuminemia, and all these were present. Her total bilirubin was 1.7 and direct bilirubin 1. OTPT were 54 and 43. Alkaline phosphatase levels were 207. Total protein was 3.3, which was very low, and albumin was 1.7 on presentation. And BUN creat was 3 and 1.1 creat. Serum sodium levels were 125, potassium levels were 2.2, and then calcium levels were 7.3. Phosphorus levels were 2.3. Then, yes.
So, did you expect these electrolytes like this? Can you explain it on the basis of anything? Did you expect the electrolytes, sodium, potassium, calcium, everything to be low? So loose stools, you're saying that because of loose stools, she's lost sodium and potassium both. But what about calcium? That is one. Secondly, are the stools so continuous and so watery? They are. Okay.
She presented with shock actually, sir. She was in shock on presentation. This almost one month passed by. Before 1 month, she presented with
Hypovolemic shock.
along with cardiogenic shock was also there, sir. She had a dilated cardiomyopathy.
The point I was trying to make is that you have to just keep thinking. So you originally said that this is some kind of a chronic intestinal inflammation, and one of your differentials is autoimmune enteropathy. Now, autoimmune diseases are often multifocal. So you could have a multiple endocrine glands also involved in an autoimmune disease. You have a combination of celiac with uh, endocrinopathies, right?
This is the urine examination, mainly suggestive of a blood present, granular calcifer present. And this is a stool examination, which was suggestive of specific total IgA levels and TTG IgA levels were sent. TTG IgA levels are more than 200, which was high. Celiac disease is suspect, and she started on gluten-free diet, following which she started showing improvements. Her weight gain present, currently weight is. Uh, yes, ma'am. The report is in the file.
Yeah, disease that whatever I have seen is growth failure. They are quite stunted, and often the history is that the younger brother, if he's unaffected, is taller than the older brother is gaining. And of course, anemia. And intermittently, they are good and not good. But something like intestinal obstruction presenting, getting relieved on its own and occurring time repeatedly in whatever celiac I have seen has not presented. This looks something like movement disorder, where there was abdominal distension, which got relatively suddenly relieved also. The child was presented. Isn't that so, doctor? He passed gas and the whole distension got relieved. Something which is like a functional abdominal distension and a muscular tone or whatever got better, which was rather difficult to explain. But no growth failure in this child. His growth is child might be suffering from quite early in life, and she's 6 years and 110 centimeters. Weight is affected. Disease. Pardon me? Usually they present with different kinds of metabolic diseases, especially involving calcium.
So why was this child acidotic when the child came in?
She is in shock. Over organ perfusion was there. That is, yes, sir.
Fine. So now basically the treatment is just gluten-free diet, right?
These of supplementations. Yes.
Sanguinity. most of them, I have whatever 5, 7 patients I have seen, hail from North India. Okay, this is from here, I suppose. Of course, that doesn't prevent anybody from getting a disease, but the gene is more dominant in North India.
No, sir. That cardiac dysfunction, it improved, sir. Her ejection fraction has improved to 60% now. Everything has settled down. Only now her recovery is going on. She's still on anti-failure medications, but she came in a very bad state with all that emaciation, with so much electrolyte disturbances.
Did you do her vitamin D levels?
Yes, sir, it was done. She was started on cholecalciferol sachets also. Okay.
Fine. Any comments or any questions from our online audience?
What was surprising, Rajesh, in the second case is the acute deterioration in 1 year from 19 to 13 kgs.
Correct. Yeah. So there's a marked deterioration. So that way, like Khare sir was saying, we expected long-term growth failure, but
Yes.
probably the disease started a year back. So height didn't really show up so far.
Yeah. Great. Yeah. Thank you. Both unusual cases and great discussion. Thank you. Thank you, Amdekar sir. And thank you all faculty and students.
I was just trying to do a self-exercise, trying to summarize for my understanding. This child presented with intermittent abdominal, intestinal abdomen. There was nothing that was done actively for which he got better. And when he was better, absolutely nothing had gone wrong, like a functional intest. So something which we have to learn. The shock was because of profuse diarrhea. Quadrogenic cardiogen. Not seen so far.
Did you look at yourself that were the volume losses sufficient to push this patient in hypovolumic shock? Honestly, the way you were narrating the history, to be really, really very huge and watery, right?
We large profuse quantities stools.
Fine. So you probably didn't mention that way, or at least I didn't register. But my point is different. My point is that the occasional case of, let's say, cortisol deficiency or something which you will see is when you can make out that a patient has come in shock disproportionate to the losses. That is when you suspect that the normal stress response and push you to that kind of a thinking, that line of a thinking. Now, you said the heart function was very poor. She was badly hypocalcemic. So there is something known as hypocalcemic myopathy. It's seen in younger children. I don't know if it can be seen at this age. The fat malabsorption made you go down on vitamin D, which made her go down on her calcium level. Whether that led to that hypo function of the it wouldn't have come back to 60% now. So it was only temporarily related to some transient. So I'm just making one point that whenever you get really, that's the point.
Support what Dr. Rajesh said. I don't know whether I mentioned this patient earlier. One child, a small child, maybe few months or so, was brought in shock for a few loose motions. And for what reason, I don't know. I just removed the chadar which was kept. And she was a female child with lateral hypertrophy. It was a case of congenital adrenal hyperplasia, and she was in shock endocrinal, as he said, with few loose motions. And she was so bad, I just carried her to Baba Hospital. And when I reached Baba Hospital, the resident doctor recognized her immediately. ये तो हमारा पेशेंट है, अभी तो डिस्चार्ज किया like what said, with two loose motions, she was in shock and bad. I was lucky that it was a female child. If it was a male child, I might not have even thought of CH.
Okay. So we stop the class here today. And just to remind our online friends that we are now going to have it on alternate. So 9th October. So 2nd October anyway is Dussehra, and anyway we are not having. So it will be on 9th October, the next class, right? Oh, yeah, we'll try, definitely. Thank you. Thank you everyone for joining in. Thank you.